It gives me great pleasure to introduce Dr. Stuart Nunnally. Dr. Stuart Nunnally has an integrative biological dental practice in Marble Falls, Texas, where he and his staff have treated patients from all 50 states and 36 countries. He is board certified in both naturopathic medicine and integrative biological dental medicine and holds a master's degree in nutrition. Dr. Nunnally is past president of the IAOMT. He holds fellowships in the Academy of General Dentistry, the Academy of Ozone Therapy, and the IAOMT. He is on the faculty of the Academy of Comprehensive Integrative Medicine and the American College of Integrative Medicine and Dentistry. He frequently teaches on all aspects of biological dentistry. Please join me in welcoming Dr. Stuart Nunnally.
Boy, thank you all. It's a treat to be here. This is my going on 38th year in practice. I feel like I got an echo. And I've had so much fun. And recently I had this awesome young 91-year-old patient whose wife is 92. And he was in the office about six months ago, and I was walking by the reception room, and he just waved me over there. I walked in, and he said, "Stuart, where were you this weekend?" I said, "Well, I was right here in town." He said, "Well, you didn't answer your phone." I said, "Well, I'm so sorry." Anyway, he went on to say, he said, "No, I looked all over for you. I couldn't find you." Now, this man has teased his wife for 71 years worth of marriage. Unbelievable couple. And he said, no. He said, "Nancy had this place come up on her lip," and said, "I was pretty sure it's herpes." So I ran her I tried to find you, but I ran her to the minor emergency center. They said, "No, that's a powder burn from shooting her mouth off." And then 2 days ago, before I left to come here, he was in again. And he's always just jabbing at her and she at him. And it's just the funniest thing. And he said, she got out of her hygiene appointment and she had quite a few areas of decay. She got up to the front and they told her and him what the fee would be next time in order to get all of these areas of decay taken care of. And he said, "Well, how much would it be just to put her to sleep?" And that's no joke. But anyway, it's such a joy to be here among some of my favorite people in the world. And I'm going to talk today a little bit about what most people call cavitations, and I'll call it that because most of the people who are referred to us either have been told that they have a cavitation, or their physician or their healthcare provider has called it a cavitation. Most places in the literature it's called Jawbone Osteonecrosis. And so we're going to talk about that. We're going to talk about drug-induced Jawbone Osteonecrosis today as well. And what I want to say to you is this. There was a time when, especially early on when I started doing these surgeries, when it was suspect in terms of at least mainstream dentistry. It should not be now. There's plenty of data, great scientific data, to give us every reason to do this treatment. But I hope today when you leave that you feel like you're a little bit more armed and prepared. And if ever you need me, I'm available. I'm going to start out by giving us something to think about. This is a patient who I recently saw. 52-year-old non-ambulatory Caucasian female. She has a 20-year history of MS, and she's currently taking 13 prescription medications. And the patient presented, she was actually referred by a physician, and she presented with intense pain, and she knew she had a root canal that was going bad. But this pain was atypical for just a bad tooth. This pain was a lancinating pain, a searing pain, and the pain not only was in the area of the tooth, but it was also to the point of inability to touch her hair. Her occiput and temporal areas were all on fire. So we're going to talk about that, and I hope that sets the stage for how we would go about treating this patient today and actually making a fairly simple treatment in the end. So a cavitation really is nothing more than a stagnant area in the jawbone. Now, we have other bones that become stagnant as well, where there's just not a good, robust blood flow. It just so happens, though, that the mandible and the maxilla are the most common bones to develop osteonecrosis. The hip is the next most common bone, and then the ends of our long bones are the next most common. And I tell people when I'm trying to explain this, when I'm trying to explain it, that you have to remember, if you remember back, there was a fabulous athlete, Bo Jackson, who was a star at Auburn, and he was a Heisman Trophy winner, and he's one of those few people in the world that actually played professional football and professional baseball. But one game, I remember I happened to be watching the game. He took a blow to his hip, and his hip necrosed. And as a result of that, he lost his ability to play both professional baseball and professional football. So most people, at least my age, can identify with this great athlete and understand that, well, gosh, you know, a cavitated area can become very, very severe. It would be easy if they presented, all of them presented like this. So obviously this was a bridge, 3-unit bridge, a tooth was removed, and we were left with absolutely no radial density there, and there's no bone in there. As soon as you punch through here, you're in absolute air. And so I wish that all of them on a two-dimensional x-ray would show up like that, because it would make their life so easy, and a blind monkey could take care of it. But as it turns out, it doesn't work like that, and if we were to look at this on autopsy, this is what it looks like. This is the mushy appearance of necrotic bone. And oftentimes when we scoop these out, we'll see not only the degenerative fatty cysts, which give these an oil slick-like appearance when we open them up, but oftentimes they'll have kind of this grayish, blackish goo that comes out. Healthy bone then would look like this. This is typical healthy bone at autopsy. And then let's talk about this, because it's hard to believe that in the year 1915, now 102 years ago, this condition was first identified. It was actually identified longer than that, but in the literature that we have in the United States, it was identified by the father of modern dentistry, G.V. Black, identified him, and he wondered, how could you have something like this without it producing pus, and without redness and swelling over the tissues, and without temperature or pain, because very few of these actually are painful. And then if we follow that up to today, the most common textbook in the world on oral and maxillofacial pathology is this book by Neville, Dams, Bacot, and Allen. And again, in there on page 868, the treatment that Black recommended is the treatment that's still recommended today in the most widely used textbook on this subject in the world, and that is that the diseased marrow should be removed surgically by decortication and curettage. So if you looked at my notes, and this is what I would suggest to you if you are doing this surgery, is that you use that language. That in your notes you write down, for example, tooth number 31 was treated by decortication and curettage, and then you're following along exactly in step with what the most common textbook in the world says you should do in terms of treatment. Well, how are we going to diagnose this thing? And so we'll go through each of these, and we'll go through them pretty quickly. But one way to do it is to literally, if you suspect that a patient might have a cavitated area, is just put your finger over the area, because that area has a little more pressure to it than the surrounding medullary bone. So sometimes you can just put your finger on the area and press, and if it's tender, It's an indicator. Not a great indicator, but it is an indicator. There's a diagnostic anesthesia technique because, as you know, by the way, I know that there are people in here that are hearing about jawbone osteonecrosis for the first time. So I want to make this very user-friendly for you. But I also know we've got some folks in here who've been doing this surgery probably longer than I have. So I hope to update you a little bit for those of you who've been doing it a long time, but I'm backtracking a little bit to try to get us all up to speed. What we know is most jawbone osteonecrotic lesions are not painful. But there are some that induce an incredibly painful condition known as trigeminal neuralgia. In fact, it's my opinion that at least 80% of all trigeminal neuralgias are caused by dentistry. And it's caused by an infection in the jawbone. And what happens is we have 3 branches to the trigeminal nerve. The first, second, and third, obviously this is the inferior alveolar nerve. And what happens most often is a lower third wisdom tooth, or lower third molar is removed. An infection ensues right here, and it's in such close proximity to the nerve that the toxins from the infection leak into the nerve. They leak, and then you have this bizarre thing of retrograde axonal transport, which is very well documented in the literature. It goes up here to the Gasserian ganglion. And for some unknown reason, the pain usually manifests itself here in the second division of the trigeminal nerve. So most patients, when they come to see you, will complain of a pain right up here or under the ala of the nose. And usually they'll describe it like this. Oh, I can't touch it. No, there's no way. I can't sleep on this side. I can't let water wash over my face in the shower. It's an incredible pain, and it's certainly identified in the literature as the most painful of all human afflictions. It's also known, very well known, as the suicide disease. This is a terribly, terribly debilitating pain. I'm going to quickly tell you, I actually shared this years ago here, but it's such an unbelievable story. I'd been in practice less than a year, and a little lady in our community came in one morning and said, well, she came in like this. She said, don't touch my face, but please, can you help me? She knew I was the new dentist in town, and I'd known her all the years that I grew up in this little town where I practiced. And she came in, and I said, Miss Julia, what happened? She said, oh, honey, is there anything you can do about this pain? I said, I don't know. I probably didn't know squat about this pain, is the truth. But I barely lifted up her lip. And when I did, I saw the most unbelievable thing. This lady had 21 absolutely perfect, dead gorgeous teeth. Not a single spot of decay, not a single area of periodontal disease. The interesting thing was, when I lifted her lip up, the entire right side was edentulous. Upper left, all her teeth except for her wisdom teeth. Lower left, all her teeth except for wisdom tooth. Lower right, all of her teeth except for her wisdom tooth. I said, what happened? She said, well, honey, I had my wisdom teeth removed when I was about 40. She said, but 2 years ago, I developed a terrible toothache up here. And I went to see my dentist, and he sent me to Austin, to the oral surgeon, and he took my back tooth out. He took her upper right second molar out. He said, the pain got worse. He said, next week, took out my next molar to it. He marched consecutively down every tooth until he got to the midline. Can you imagine? All that while she had trigeminal neuralgia. So oftentimes this disease mimics a painful toothache, and it's difficult to determine the difference. The difference most often is that the trigeminal nerve, being such a large sensory nerve, has many fibers to the face. And so most often when you see a trigeminal patient, first of all, they'll describe it as a searing pain very often. And they'll also say it's very difficult to touch their face. That's typically the best way to diagnose it. Well, there have been these trigeminal patients have given us a group of patients to study, because when we get the area cleaned out, or when we get the issue resolved in terms of cleaning out the osteonecrosis, the pain goes away. In fact, in the 1970s to 90s, there were 12 studies done. There are exactly 2,000 patients in these studies. And in those studies, believe it or not, when the treatment was done, in other words, when the area of disease in the mandible or maxilla was cleaned out, 75% of the patients got total relief from their trigeminal neuralgia. 20% got better, 5% got worse. And that's exactly what we've seen over the years in our own practice. 75% about of the patients that we see get better. 20%, get completely better. 20% get somewhat better. And every now and then you'll have one. I just had one 2 weeks ago that got worse. So it can happen. So, and the interesting thing is there's not much difference in terms of how big the area is as to whether it's painful or not. It can be the size, believe it or not, of a BB. And it also could be the size of a pecan. Every now and then we run across a lesion that you can put your thumb in. Usually they're more like the size of an acorn, maybe a centimeter in size. So how do we diagnose this thing? Well, if you have that kind of pain, if you have trigeminal pain, and I want to give you a little test here that you can do that will absolutely bless your patient's socks off in years 2. If you have a patient who comes in and says, I can't touch my hair, I can't touch my face, it feels like it's an upper molar, what you do is you look to see and ask them if they ever had a wisdom tooth removed, because there's a very good chance that if you put a little anesthetic over the lower wisdom tooth site on the same side as the pain will go away. It's the most awesome thing to see. To put a little anesthetic, for example, over a lower right third molar site, and the patient go, I can't believe the pain's gone. It's unbelievable. I can finally touch my face. And when you do that, the wonderful thing about it is you've identified the source of their pain. So the anesthesia technique is right there. And it's one you should keep in your back pocket, because in the course of, now I see many of these patients, but every dental practitioner sees an occasional trigeminal neuralgia patient, and you can really help, pinpoint these areas. So radiographs are only minimally helpful, because in order to see a lesion in the bone, about 50% of the medullary bone has to be destroyed. And rarely ever, when you have a true jawbone osteonecrosis, rarely ever is the cortical plate destroyed. So you can't see these all that often. I think the more you treat them, the more you can see them. But to tell you the truth, I never knew how to look for this 20 years ago. I had no idea that they even existed. And so many of these passed by me without ever being detected. Sometimes people ask me, say, do you think if I do this treatment that I'm going to be held liable? I said, I think if you don't do this treatment or tell somebody that they may have an osteonecrotic lesion in their mandible, you may be liable. And you'll see why in a minute. You'll see the toxicity associated with these. And so, what about a cone beam? Well, I think quite frankly today we would have to say the cone beam is the gold standard for detecting these, and yet I will say that they still don't all show up on a cone beam. I like the cone beam, and we've gone through two cone beams in our office. The first one had the Hounsfield unit. Hounsfield units measure relative density. Our first cone beam was a Plan Mecca, and it was very nice because it had Hounsfield units on it. And what it would do is it would give you the relative density of this, as opposed to, well, look at the density of the tooth. 1182, and I'm not even sure what the units of measure are. 3095 for a crown, so it's super dense. And then when you go to this void, which is obviously a cavitated area here in the mandible, there's a negative 232. So that's a lesion that's just like that last lesion that we could see on a two-dimensional x-ray. And so this would be an area that we could just hang our hat on. There's a guaranteed hole in that mandible and it's full of bacteria. So I like Hounsfield units, and we have a study designed to try to confirm now that Hounsfield units are a great way to diagnose. Now, by the way, if any of you are doing this treatment and you have a machine, either Anatomage, which is a software that can go on various cone beams that'll give you Hounsfield units, or you have a planned MECA and you'd like to participate in a study in 2018, I wish you'd see me during this meeting. So, the other methods of looking at this, a CAT scan and an MRI are just useless to us. And the ultrasound that we used to have using a cavitat, obviously some people still have cavitats, and I think they're tremendously helpful. But that technology, although it's still around, there's no support for it, and the gentleman who developed it has passed on. So right now we're stuck. By the way, I think the ultrasound is about to come back around to us. There are some people in Germany who are working on it, and I think there's some people in England. So hopefully we'll have that again available to us at some point. Until then, cone beam is probably the way to go. This is what it looks like at surgery if you're bold enough to go in and dissect out the inferior alveolar nerve. So I'm not, but these fabulous dentists in California were. I don't dissect out the nerve. I'll get to it sometimes, but I don't want to run the risk of having a patient with lifelong paresthesia or anesthesia. So when you see on a two-dimensional x-ray, you see what we would typically call ghost marrow, these areas where the roots still show themselves, and it's a year or at least 6 months past the time the tooth was extracted. You can bank on that being cavitated. You can bank on that being diseased bone. You can see it here very clearly, the outline of the roots. And if we just punch through there, you'll fall right into a hole. And that's what it looks like at surgery. You can see down into where each root was. And we clean that out, and I'm going to show you in a minute how we go about getting a good healing response. Again, at autopsy, this is what the bone can look like. These are all courtesy of a fabulous friend and mentor, Dr. Wes Shanklin in Columbus, Ohio. They had a project where they autopsied many. They did this cadaver mandible project years ago, and these slides are fabulous. So what's the risk of not doing the treatment? So you have a patient, and let's say you're able to identify even on a two-dimensional x-ray, and they say to you, well, these have never bothered me in the least. Well, here's the risk. When you leave an infection or a persistent condition like this long enough, it can become a real systemic risk factor for thromboemboli. So you're making a trip over to Germany and you develop a DVT. Maybe it was caused from your jawbone osteonecrosis. Maybe it wasn't. You're also more at risk for other areas in the mandible or maxilla to develop. So typically, if we're cleaning out one area, we usually get them all at the same time, because who wants to leave anything behind? Well, years ago, we were able to send the contents of these off for an analysis. This was a toxicity analysis that was done in Lexington, Kentucky, back when Boyd Haley was involved with Alt Bioscience. It was a fabulous test. We tested hundreds of these. Not a one out of hundreds ever came back that wasn't severely toxic. So it's just good old standard toxicity testing. And then there's a wonderful man who's lectured to our group before. His name is Hans Lechner. And Hans now has about 6, I believe he has 6 papers that have identified a cytokine, which is a chemical messenger. Cytokines are chemical messengers in the body. Some of them are identified with health, and some of them are identified with disease. In this case, he has identified a cytokine that he never expected to find. It's called Rontes. And if you look in the literature, Rontes is all over the literature, because virtually every known pathological condition you will find has an elevated Rontes with it. Well, this remarkable German dentist and scientist has now identified that in areas of jawbone osteonecrosis, the Rontes is elevated 35 times that of the normal healthy bone. And what he's done is he has even established some great controls, because he places zirconia implants, and when he trephines the bone, he'll take a plug of that, and on the same patient that he's doing a cavitation on, so he has a wonderful control. He can show that the bone from which he's from his implant site is normal and has virtually no Rontes at all associated with it. But the bone from the osteonecrotic area has high levels of Rontes. He now has a follow-up study which shows the relationship between this and breast cancer. So I highly recommend that you go to, and I'll have this, this is Lechner's research. These are his 4 latest papers. If you go to Science Direct, you will see all of his papers, and just type in Lechner, and they're fabulous. I hope we have him back for our group to lecture again. And by the way, he's hosting IAOMT next year in Europe, in Munich, in May. So you'd have a chance to go hear him lecture if you go. And now, of course, we also have DNA studies available to us, so we'll take the contents of this material. We don't have to have much at all. We put it into a little sterile tube. Usually we pipette it. We have a little pipette that we stick into the lesion, suction it out, put it into a tube, send it to Colorado, and several weeks later we get this report. This shows 26 different anaerobes that were in this particular cavitated area. So, why wouldn't antibiotics be effective on this? Well, there are many reasons. One is there's a very poor blood supply, so the antibiotics can't get to it. The other is there's this intramedullary pressure that's 2 to 4 times that of the normal marrow, so it precludes things from being delivered to it. It's one of the reasons why oftentimes when we open these up, as soon as we punch through, it spills out quickly because it's under pressure. And again, it looks very much like an oil slick, because when you get an area, an osteo or a necrotic area in the mandible, and you get this pressure behind it, you'll develop degenerative fatty cysts. Medullary bone's somewhat fatty anyway, but you'll develop an abundance of fatty cysts, and they'll absolutely just roll out. And that's part of what we collect and send off. Well, to treat or not to treat? That's the question. So you have the patient in the chair, and the patient says, well, I can see, doctor, where you're showing me I have this lesion in my mandible, but it's not painful. I'm not going to treat it. Well, that's somewhat understandable. It's not smart, because his periodontal disease is not painful either, and his cancer is probably not painful, and his heart disease, until it gets to end stage, is not painful. This issue needs to be brought up, and we need to address and we need to educate our patients. Listen, when I first became aware of this, I had 22 years worth of patients in my practice who had never heard about this. So this has been a process of educating my patient base. Did I go in and tell the first patient the first morning that I learned about? By the way, I had these all cleaned out myself years ago in Montreal. It was quite a motivator for me to learn how to do the procedure, because it was so impactful on my life. It truly, I think it gave me, within 2 weeks, an energy that I hadn't had in months. And so I will share with you from a personal experience, I have no problem at all telling someone, you know what, I think you might have a cavitated area in there and we ought to check it. I want to do it on your timetable, but I just want you to know about it. And the reason I want them to know about it is Because what if they get mad at me and they go see my dear friend Dickie Stanley or Logan Stanley in my same town, and I haven't said anything about it, and they astutely say to him, you know what, I think you've got a cavitated area. Well, I wonder why old Nunnally didn't say anything about that. And to tell you the truth, I feel like I'd be liable because many of these sit in the third molar site, which is on the heart meridian, and regardless of whether it's on the meridian or not, it's an infected area, and we should let our patients know about it. So I'm going to show you an easy starter case if you've never done one of these. This was an abscessed tooth. The tooth had a crack in it and a lesion. And there's the, can you see that? A little bit of a radiolucency. So the tooth is out. All you have to do is punch. Just punch through there. And you're right into the lesion. No incision necessary. I share this with you to say the next time you take a second molar out, upper or lower, punch through and see what you find. You're not going to do any harm. If there's nothing there, you'll just increase the blood flow. But usually you'll fall into no man's land back here. And you can simply clean that out and then you'll fill it up, and I'll show you how to do that. I'm not going to go on with this as a surgery that's difficult to see, but I will show you one other that's easy to see. So many times, obviously, people have had bicuspids removed for orthodontic treatment. This one was the first bi that was removed, and so this is a real easy one to see. We just make a simple, beveled, all the way to bone incision. By the way, these incisions are small, and today, using platelets, I rarely even suture them anymore. There's no need to suture them. So we'll take that, and then Schumacher has made a whole set of instruments just designed for cleaning out osteonecrotic lesions. This is a little tiny periosteal elevator, and we can lift the tissue off real gently there without tearing it. So we lift it off. It's a full thickness flap. And all we do is take a number 2 round burr and go right into the site. I like to use a straight hand piece, and that's going to be operating, that's an electric hand piece at 2500 RPM to decorticate it. And once I get through, I keep cleaning it out with a round burr, but less than 1000 RPM, just real slowly, debriding it out. Then I take, when I feel like I have it cleaned, I take an Explorer and I check for any little wormholes or areas that I might have missed. Ozonate. This is 20 mics of ozone until I meet resistance. The patient's asleep, so they can't tell me whether they feel pressure or stinging. We always use in our office when we inject with ozone and the patient's not asleep, we simply ask them to tell us if they have pressure or stinging. And when they do, we stop. Now, I usually have given Procaine in advance. I love to use 1 or 2% Procaine. So that's it. There's 24 hours. That was even before we started using platelets. With platelets, you can hardly tell the next day that we were there. And the patients really can't. So I'm just going to share 1 or 2 things with you. That was such a marvelous lecture this morning to lead off by Dr. Myron. And here's what I want to say to you about platelets. To me, platelets are the biggest game changer in all of what we do in terms of surgery and dentistry. And I had my world rocked a little bit yesterday because I sat in a lecture with Greg Steiner. And Greg had a slightly different opinion of platelets. Now, I went back to my wife, Rebecca, and I said, honey, I don't know if I'm going to give that lecture tomorrow. He doesn't have the same feeling about platelets as I do. This is year 5 for us to use platelets. If I had to leave the United States of America, I would take Rebecca, my grandson, I would take IV vitamin C, my ozone machine, and a centrifuge for platelets. That's about all I need. And so I just want to share with you, I have a love affair with platelets. They're unbelievable. And what I didn't share with you a while ago in those 12 studies that have been done to determine the success of jawbone osteonecrosis surgery, 40% of them failed. 40% had to be redone. Now, in none of those did they do any of the protocol that we follow today, and they certainly had no platelets. But I think in our own practice, and Dickie and Logan and I have done this surgery very, very similarly for years, I personally think that we probably had about 10% fail for 12 years. And now I think we're close to 0% failure. Platelets have made that much of a difference for us. So I'm not going to go through this whole process because Dr. Myron was kind enough to take us through it better than I could have ever done today. One thing I will say is the platelets are wonderful, but those amazing growth factors are every bit as wonderful. And I want to share with you how important I think vitamin C is. Because of a whole host of reasons. One is you get much quicker healing time. The patient typically just responds in half the time, and we have over 50,000 peer-reviewed studies now on vitamin C. There's just no reason to use it, but this is the single main objection right here to the use of vitamin C. When you tell your physician that you're going to use high-dose vitamin C, so well, I wouldn't do that, it can cause kidney stones. And that it's interesting how that myth has been promulgated for all these years. There's absolutely no truth to that whatsoever. There is one patient that you need to know about where you don't want to use. By the way, there are 2 studies now, one male, one female, 80-something thousand each one. No, vitamin C in no way exacerbated the patients having kidney stones at all. In fact, they had less kidney stones. So you don't swallow that one. But I will say that you do need to know this. If you're going to use high-dose vitamin C, you need to know that there is one patient who you need to be very careful about, and that's a patient who has G6PD deficiency, glucose 6-phosphate dehydrogenase deficiency. It's an enzyme that helps hold our red blood cells together, and occasionally with high-dose vitamin C, the vitamin C, it looks like, precipitates a hemolytic event where their red blood cells fall apart. Okay, so I will have to say that we now are approaching 20,000 vitamin C's in our practice over the last 15 years. We're right at 20,000, and believe it or not, I've actually seen 3 cases of G6PD. And so there may have been others, but these are 3 that we detected. And so if we have a G6PD patient, we just keep the dose of vitamin C much lower. There are no recorded incidences of a hemolytic event in someone who's had less than 40 grams at a time. But if we have a G6PD patient, we actually keep it at 25 or less. Okay. So let's talk about not Dijon mustard, but this is drug-induced jawbone osteonecrosis, or in the literature you'll see it as drug-induced osteonecrosis of the jaw. And so let's just talk about it because it's so prevalent. And the most prevalent place, because many of you have already seen this, is a lesion on the lingual of the mandible back behind usually the 2nd or 3rd molar. And you'll see that tissue is very, very thin. The teeth load onto that area, so there's more loading. And actinomyces is the most common pathogen in these. And 50% of the exposed bone will heal spontaneously if appropriate drug holiday is taken. Now, back a few years ago, Griffin gave us a beautiful paper, a published paper, on helping to speed the healing of these using ozone. I thought it was fabulous, and you should go, if you're interested in this, and see or talk to Griffin. He's here. Talk to him about the technique that he used to get this area to sequester and to heal up on its own. But for the most part, if you see an area like that, and if it doesn't feel loose, you don't have to do anything about it other than support them with ozone. I'd support them with ozone and ozonated oils and just let them know that things would get better. If you need a great reference book for this, you'll go to Robert Mark's book on Jawbone Osteonecrosis. He's the professor of oral surgery in Miami. I guess he's not there right now, but he's written a wonderful book on jawbone osteonecrosis and the management of this disease. So your patient, let's say, has been on Fosamax for 7 or 8 years. This is so very common, by the way. The FDA has said there's no reason for anyone to be on Fosamax for more than 5 years. It's done all the good it will ever do. And I would say it's done all the harm. It's just awful. It's an awful drug, in my opinion, except for one case. And Zometa and Reclass are both 9 months. These are given IV, and this, of course, is taken orally. And if you have a patient who's been on these, they need to have a 9-month drug holiday before you do surgery. Prolia and Xgeva are both the new denosumab drugs. When you see MOB on the end of anything, it means it has a MOB of side effects, but the MOB means that it's it's from a mono antibody. That's what it is. It's an antibody produced by an immune cell. So these two drugs are actually the same. They're given at different doses and different time frames. But the interesting thing about these have a 26-day half-life, and the bisphosphonates have an 11-year half-life. So if you took Fosamax for a year, 11 years from now, you're still going to have half of it in you. And that's the reason why it's such a toxic drug. It's an incredibly toxic drug to osteoclasts. So you don't break down the bone, you don't get bone turnover, and what happens is you end up over time having brittle bones. They may appear more dense on a DEXA scan, but they're more brittle. And it's very well documented now in the literature. If you have one of these patients and you feel like you have to do surgery, or your surgeon feels like he has to, this test right here, which is described very well in Marx's book, is a CTX test. You can do the test, and if the patient comes back and they have less than 100 picograms per ml of calcium in their blood, well, they're at very high risk. In other words, the bisphosphonate has their osteoclasts so tied up, they're not turning over the calcium in the bone. There's no calcium showing up in the serum, okay? But if you see 150 or thereabouts, between 150 and 100, you're at moderate risk. And if you're above 150, you're at low risk. So then you can probably go ahead and do a surgical procedure on the patient. You have to be fasting when you do this, and the cost is $200 to $300. So let's go back now to the case study. Here's this awesome 52-year-old lady, and she presents to our office the long history of MS. She's brought in a wheelchair by her son. Her son tells me this is the toughest woman he's ever known, that he's almost never seen her cry in his life, and she is absolutely in this unquenchable pain. We do because I got her history right then, I said there's no way I can do your treatment. I've got to get a CTX test. She had a Zometa injection scheduled for the next week. Sure enough, her CTX test results came back. She had 142 picograms, which just put her to moderate risk. I thought she'd be honestly in a very high risk category. We looked at her 2D x-ray, and this is what it looked like. This was her endo tooth, and look how it looked on the 3D. And that's typical of what we see, isn't it? For those of you who have a cone beam, most often the 2D pictures end up having a lesion somewhere. So this one had this large lesion, and because of all of her complicating factors, and she lived 2 hours away from me, I asked a dentist in the neighboring town if he would please give this lady ozone injections every other day for 2 weeks. So he did, because the literature supports us doing this. Thank God for the Italians who have been doing ozone therapy for years. There are 3 Italian studies that talk about pre-treating an area with ozone prior to surgery, and the wonderful success they've had because they open up the vascular beds and all the other wonderful things that ozone does. So she couldn't make the trip back and forth to Marble Falls. A wonderful dentist gave her ozone injections. Believe it or not, her pains almost totally subsided. She came back in, and here's what happened. She had those 6 ozone treatments by my friend. We extracted her upper left molar. We gave her 20 gamma of ozone, high dose vitamin C, 50 grams during treatment, and the following day packed it full of platelets. She had three acupressure sessions. She went home and healed uneventfully. We've had now several of these patients, one recently who was a physician, long-term use of corticosteroids for lupus. Also 8 years on alendronate or Fosamax. We treated her in the same way. We had to remove a tooth because of it. Just the patient couldn't continue to live on antibiotics forever, and she healed uneventfully. So that is it, and thank God those resolved. And there, my wife, if you ever come to the hill country and you want to go out and harvest bees with harvest honey with my wife and me, you're welcome to do so. Thank you very much.